All right. Hi, everyone, and welcome to Translational Medicine Day 2021. We're so excited to have you here. Just a quick disclaimer before we begin that we are recording the session. So if you would like to, you can turn off your video, mute your audio. But as always, we encourage you to turn on your camera and be interactive because our presenters are here to answer your questions and get to know you all. All right, that being said, I'm going to introduce myself. So my name is Rachel Leanne. I am this year's TMD co-chair. I'm a bioengineering student here at UCSD, and I'm an officer in the UCSD Biomedical Engineering Society. And I'll let my co-chair Karthik introduce himself.
Hi everyone, my name's Karthik Raj. I'm a bioengineering major, my third year at UCSD. I'm also a co-chair of Translational Medicine Day and an officer of UCSD Biomedical Engineering Society. I just want to say thanks everyone for showing up today and attending one of the main events of Translational Medicine Day, which is our keynote speaker event. Our keynote speakers are usually chosen such that they embody the essence of translational medicine. And with that being said, I'm proud to announce that today's Translational Medicine Day's keynote speaker is Dr. Jessica Nador. So this is a few keywords and for Dr. Jessica Nador. So Dr. Jessica Nador is the current director of community engagement at UCSD's Altman Clinical and Translational Research Institute. He's also the associate professor of the UCSD's Herbert Wertheim School of Public Health and Human Longevity Science. His research is primarily focused on improving patient-provider communication and health literacy. He is also a key advocate for improving the access and to early detection and prevention methods for cancer among poor and underserved populations. And this is only a key snapshot of his work, but I would like Dr. Jessica Nador to take over from here to give us the full, clear picture. Yeah.
Okay, awesome. Hopefully you can all hear me. Thumbs up from those of you who have images if you can hear me, and we're kind of get going here. Okay, awesome. Let me share my screen. Okay. Can you all see the PowerPoint?
Yes.
Okay, great. First of all, thank you, Rachel and Karthik, for the invitation. It's my pleasure to be able to bring a little bit of the work that I do and encourage you to add community, as the title states, to the bench to bedside continuum. And so I'm going to try to make the case for the importance of adding community to the work that you all are either already doing or about to embark in your careers. So if you're a science fiction fan, you will immediately recognize this image. In the movie The Matrix, there's a pivotal scene where the protagonist, who you see back there, Keanu Reeves as Neo, Morpheus, Lawrence Fishburne, offers him 2 pills. And he says, if you take the blue pill, the story ends, you wake up in your bed and you believe whatever you want to believe. So in other words, he would stay in the Matrix. However, if he takes the red pill, he will stay in Wonderland, and he's going to show him how deep the rabbit hole goes. So today is a little bit like that, in that many of you probably have not really thought about this next level beyond clinical or what's called bedside, in that bench to bedside continuum. And so I'm inviting you to kind of come into the expanded reality of what that would actually mean. So that's what we're going to explore a little bit. I'm going to go over a couple of quick learning objectives. No, this isn't a class, but it's always good to kind of have a little bit of guidance in terms of what the takeaways would be. I'm basically going to talk about why we would want to emphasize, or why you would want to emphasize, community in translational medicine. How to get from here, the bench to bedside, to there, the bench to bedside to community. And I'm going to talk specifically about some approaches and some potential tools that will be helpful to introduce yourself to this world, and then question and answers. And I'll try to monitor the chat if things come up immediately. You know, this is largely going to be a presentation, but there will be a little bit of interaction, particularly at the end. So we'll go through that. All right. So our learning objectives are for you to gain a little bit of basic knowledge about the principles for community engagement. I'm going to share those with you. And then to understand the role and importance of community academic partnerships in fostering highly relevant public health research and evidence-based practice in order to explore the possibilities for community and prevention in translational medicine. So it's that combination. So we would ask this question, well, why emphasize community in translational medicine? This is what UC San Diego bioengineering is described on your webpage as, right? So you can read there what the purpose is: improve health quality of life, applying engineering and bioengineering principles. It's definitely an emerging field, right? It's one of the youngest engineering disciplines. It has a broad spectrum, which already is giving you a clue that it's intended to be all, have various layers. So it's open in my mind. And you're at an institution, as you've seen with COVID, we here at UC San Diego are on the cutting edge, and I think can continue to expand boundaries. So that's what I'm suggesting, that the addition of community would bring us into. A little bit more in terms of UCSD, having this cooperative agreement within the School of Engineering and Medicine. Well, this year, UC San Diego basically established a School of Public Health. And so this new school, ideally, a year, 2 years from now, this description would be expanded to, say, engineering, medicine, and public health. And you all, I think, can be a part of that expansion. And then as you read down towards the bottom, you basically see that a lot of the focus is on the diseases that, quite frankly, are societal in terms of the cause. Cancer, I mean, over more than 60% of cancer risk is actually preventable, because it's linked to behavior and other exposures. The same for cardiovascular disease, the same for metabolic disorders, cholesterol, high cholesterol, and so on. And I'm specifically going to focus in on one of those areas, one of those primary risk factors, actually a risk factor for all of those diseases, which is obesity. This is how BMAS, which I assume if you're not a member of, you soon will be a member of, the Biomedical Engineering Society. This is how BMAS describes the discipline. And you can see basically translational medicine is a new discipline in biomedical research that aims to expedite the discovery of new diagnostic tools and treatments by using a multidisciplinary, highly collaborative, bench-to-bedside approach. This is another change that ideally, a year or two from now, it would say bench-to-bedside to community approach. And hopefully I will be able to make the case why that should be so. So in terms of identifying real societal needs, one model that we use in public health, if you've taken any public health classes at all, or sociology classes, which you probably have not if you're an engineering student, there's a model called the socio-ecological model. And basically, the premise that I'm trying to point out here is that, in effect, translational also means multi-level. And the premise of the socio-ecological model, in this case, this example is specifically focused on cancer. You basically have factors at multiple levels that are affecting a given outcome. In this case, going from the individual down, improve quality of cancer care, and then improve cancer-related health outcomes, meaning that you're less likely to die from a cancer. Having those outcomes require interventions at various levels. Much of the work that you do as a bioengineer is probably at the tissue level, or with animals, for example, or at the patient. This is largely the clinical part, and that's where it ends. What I'm suggesting to you is that considering what happens above that, the family and social, the families that these individuals live in, the clinicians that they interact with. This is actually technically part of the clinical side, on the bedside part of it. So technically the providers there. But then if you keep going up, you get into higher levels and higher contextual influences. So there's definitely these outer circles. What I'm suggesting is that you talk to folks who are there, listen to what they're saying, learn from them, and find those needs and resources that are relevant to your work. And that's what we're going to talk about, how you kind of get there. One of the key, if we go back to the model and you look at the state and health environment, or even national, but the state and health policy environment, the main infrastructure for that here in San Diego County, our quote county health department is called HHS, Health and Human Services. And this is a model that they embrace. It's called 3-4-50. And basically, this should look familiar because it's actually in the BMES definition, right? Basically, 3 behaviors, no physical activity, poor diet, and tobacco use, lead to or result in 4 diseases. Do these look familiar? Cancer, heart disease, type 2 diabetes, lung disease. They're the same ones that you saw in the BMS. And these contribute to more than 50% of the deaths, not just in San Diego, but in the US and the rest of the world. The point is, this is what's up in those higher circles in terms of the activity that's going on. And in public health, the discipline that works in this area, they're called epidemiologists. Everybody knows what epidemiologists are now with COVID, right? With everything that's going on. But so what I'm saying is that these risk factors or behaviors over here, the risk factors linked to these behaviors, are very, very important because they are causing the most significant morbidity and mortality, and that we see across various factors. And we're going to get a little bit into the granularity. But if we look at lack of physical or limited physical activity and poor diet, what we're basically talking about is obesity. And I didn't run across an animated version of this, but I'm going to walk you through basically the changes that have happened in the last 20 years to 25 years in this country. Just to kind of give you a little focus here, this is obesity trends looking at body mass index. This is San Diego County over here on the left, and this is the United States, obviously. The thing to pay attention to is the year. So this is, by the way, BRFSS stands for Behavioral Risk Factor Surveillance System. This is a cross-sectional annual survey that's done around the country that individuals complete, and it basically asks them all kinds of questions, in this case about obesity. And what you'll see here is that all the states that are in white, there's no data. The lighter blue, obesity is less than 10%. California and San Diego are at less than 10%. San Diego, in this case, is at 7.3%. A couple of these states up here are between 10 and 14% obesity. And then nobody is at 15 and 19. Okay, so that's what you want to look at. We go 5 years later, and already the majority of the country is now, you have data, and you're between 10 and 14%. San Diego's already at 10.7 by 1990. If we switch over to 5 years after that, now we have a new level, 10 to basically up to 15 to 19%. The folks who were at 10% are now above 15%. San Diego went from 10% to almost 15% as well. 10 years after that, or 5 years after that, you now have a new category, greater than 20% obesity. And San Diego's already jumped up to almost 20%. by 2005, we now have another new category, greater than or equal to 30% obesity. And you can see that there's a concentration in southern states, and San Diego is kind of holding its own there at 21. And the latest data on the BRFSS 2019, so they're about a couple years old, basically show us in California, not just San Diego, you basically see that obesity is right around 25%. So it's pretty much held kind of plateaued there. Overweight, however, nearly 36% of individuals are overweight, meaning a BMI between 25 and almost 30. A BMI of over 30 will qualify you as obese. One of the takeaways here, though, is, and this is when you begin to have dialogues with communities and at a societal level, you basically begin to look at the details, as it were. And with regards to obesity, one of the key details is, well, who is it that falls under this with regards to individuals? What are the characteristics of these individuals? We in this country are still pretty much stuck on on not necessarily directly measuring socioeconomic status with indices per se, but indirectly measuring it through race and ethnicity. And by the way, if you haven't studied these areas, ethnicity basically is anybody who's Hispanic, and race is, so race would be African American, white, Asian Pacific Islanders, and so on. So really Hispanic is the only ethnicity. Hispanics can be of any race, so not to confuse the issue too much. But this is what you would want to look at here. And usually white is the referent. Whites tend to do better on most indices. So if you look at obesity, the second highest are, or the highest is actually African Americans, Black and non-Hispanics, followed by American Indians. And way down here are Hispanics. And the lowest rates are among Asian. Now, Asian is a huge group, as you know, especially here in California. For example, the largest Asian Pacific Islander group here in California is actually Filipinos. But we don't have Filipino data. It just has this aggregate. So you would absolutely want to dig into those subgroups and figure out what you're looking at. And the point, though, is that there are, when you start thinking about obesity and the health issues that obesity causes, and you ask yourself as a bioengineer, well, which population should I be paying attention to? These are the kinds of data that that give you a clue in terms of where to focus. Now, how do you get more immersed in adding that community portion? How do you as a bioengineer begin to learn a little bit more? Well, fortunately, as I mentioned, the School of Public Health is new, but the bachelor's in public health and master's, there have been opportunities. Most recently, we have actually begun a dialogue between the School of Public Health and engineering. And so this would open up classes for engineers to learn about public health. So that opportunity is there, or will be there soon. The institute, the Altman Clinical and Translational Institute, which you should go to the webpage, the ACTRI, explore a little bit. And one of the areas you'll run into is this clinical and translational research training, CREST. And there are opportunities to take classes there that will bring in some of this. So training is one way to kind of begin to add in community and cross that bridge. The other is, which is very important, is more and more now there are the funding organizations. The National Science Foundation is one of your primary funders. Like I've never applied for an NSF grant until last week because we're beginning to explore these partnerships. This mechanism right here is called Smart and Connected Communities. So the folks who we've partnered with to submit this grant, you will probably recognize their names. Dr. Andrew McCullough, Benjamin Smar, Daniela Valdez-Yasso. These are all your faculty. And so those names are people who, your colleagues or your professors, your faculty, who are already looking at this, considering this. And if you are interested in this, I would go talk to one of those three. Dr. McCullough is probably the busiest, right? He is one of the heavy hitters, full professor and so on. But Ben Smar in his lab, they may have some time. Daniela Valdez-Yasso, my understanding is that she's an excellent mentor, particularly for first generation students. So if you're interested and haven't reached out to her, I think she would be a great person to talk to. The ACTRI has pilot grants twice a year, and or once, I think it's going to twice. And that's another opportunity to ask the question, as a bioengineer, what kind of communities or community organizations can I partner with to begin to explore this issue? Say obesity, for example, if you're interested in that. And as the new director of community engagement, I'm working with a team to pretty much revamp and really be more proactive in bringing community even within the ACTRI, because ACTRI has had community in that component, but it's still largely focused on the bench science, the basic science, and clinical. So the community is just kind of sticking on, but we're changing that slowly, hopefully a little more rapidly. But anyway, so some of the tools, I think there are two tools that I can point you to. One is the principles of community engagement. And by the way, the funder for the Altman Clinical Translational Research Institute, by which it is called the National NCATS, the Clinical and Translational Service Awards or Science Awards mechanism. If you go to the NCATS or NCATS webpage, you're going to learn a lot more about that infrastructure and what resources are there. So I recommend that you go there. So if you are interested in interacting with community, this is a great resource. And the link is right, or the link, it's a PDF, is there. And these are the kinds of things that are really critical before you go out and start interacting with community partners. Having a clear goals and purpose of what it is that you're trying to achieve, getting to know the community, and I'll come back to that in just a sec. Establishing relationships and commitment, respecting collective self-determination of the organization. We, as academics, think, especially without any training, or if we haven't really had this orientation, we're with UCSD and we're here to help. That's not the way to go about this, partnership building. And then, recognizing the community's diversity, using community assets and strengths, not just the deficit model. Oh, you have this problem that I'm here to talk about. No, all communities have both needs, but also have resources and assets. And like I said, sit, listen, and learn. And then, of course, being flexible in terms of what you're looking for within your dialogue, and hopefully forming long-term commitments. As a student, you probably aren't going to be here much longer beyond graduating, but once you are, established somewhere, developing these relationships is really important. And the way to do this, going back to 2 and 3, know the community and establish relationships, is to figure out what area you're going to work in, find the kinds of organizations you want to go work with, and go hang out with them way before you start writing a grant. Make friends, start learning what their needs are, start bringing them into defining that research question or that area that you want to work with. That is the secret. And that's the way you want to approach it. I'm assuming you haven't done any community work. I'm not going to go into details here, but there is this resource called the Community Toolbox. There's the link there. Anything and everything that you would want to learn or know about community engagement, how to gather information, how to plan, it's in that tool. So that's a very important tool. All right, so let's do a little exercise. If you, in the chat box, there's a link I'm going to stop sharing that. And I'm going to go to, let me see.
Yeah, I think the link is in the top of the chat.
Yeah. Okay, I'll know. I want you to go hit that link and it's going to take you to this page you're seeing on the, do you see the page on the screen where it says my career passion is? I don't see anybody populating it yet. Okay, yeah, people are joining. You're going to join this anonymously, by the way, when you get, so I know the link works because somebody just joined. Go up to the chat and just click on that link. Okay, let me see, there's a question up there. Can you send it again?
Yeah, I think
there it is. Thank you, Karthik.
Yeah.
Okay, yeah, you guys are all on. Okay, here's what I want you to do. So in case you haven't used Jamboard before, let me give you a little quick orientation to the way this works. Up here, you basically have two questions. This is the first one. And if you go up here to the center at the very top of the middle where it says 1-2 and there's a little right arrow, if you click that, you're going to go to this question in the bench side. Okay, so that's how you get between the two questions. Go back to the first one, click back. I mean, if you see it on your screen, because here's what I want you to do. Go down here and click on this where it says sticky note. It's like 1, 2, 3, 4. It's the little box with the 2 lines in it, and it's going to bring up a note. And that's where you would type, and you can change the color. You'll see yellow, green, blue. You can change the color. Type the answer to the question, and then hit save, and then it'll basically show up. Whoops, I don't know what's going on here. I don't see the question anymore. Oh, there it is. My career passions. Okay, so your sticky note will show up here. So just take a minute to do that. So go down here to this little where it says sticky note on the left-hand side, 4th little icon. Give me some input here. Have you guys been able to find the sticky note?
Yes, I've been able to get it.
Okay, great. Somebody did it. Okay, there you are. There you go. Okay. By the way, you guys can move everything around. Just when you put them there, just leave them there. I'll move everything around because you guys have full control in the same way I do. Okay, so I'll separate them out. They all kind of land up here. There you go. Okay, perfect. Okay, let me, while you guys continue doing that, let me read a couple of these. To become a doctor and take care of patients, to earn a PhD, to make impact on the community. Awesome. To work within the bioinformatics industry, become a research faculty member, improve existing medical devices and technology, work in R&D, research and development in a company, develop medical robotics that can be safely and easily used in a hospital setting. Design innovative medical devices. Okay, awesome. So let me just take one of these, one that's common. Okay, like this one right here, for example, design innovative medical devices. Whoever, who wrote this? Just unmute yourself and chime in.
Oh, actually, I wrote that.
Oh, okay. Well, Karthik. Now let's not choose one of the leaders. Let's choose somebody else. Okay, how about this one? Who wrote this one? Very similar. Improve existing medical devices and technology.
Oh, I did.
Okay, is it Chelina?
Yeah.
Or Helena?
No, it's Shalina.
Chelina. Okay, awesome. Okay, so what I just talked about in terms of community engagement, thinking about that, what approach would you use to begin that dialogue?
I suppose it just have to be like reaching out and spending more time with people in need of these medical devices. Say if I want to work on I I don't know how to pronounce it, but like hearing aids.
Okay, yeah.
Say
sure.
I want to work with hearing aids.
Yep.
I haven't spent like much time around like the people who are deaf or like the deaf community, so I would need to take steps to make sure like I interact with them and I actually can serve them instead of like randomly bringing them this cool thing that I think of that doesn't really help them.
Exactly. So I think I would remember those circles that I was talking about. When you go and you start preparing and reading, one of the things that you might discover is there's going to be a huge need in that area, in the same way there's going to be a huge need in glasses. Anybody know why? What's happening to our country?
An aging population, for one.
Yep, exactly. That, the fact that you have an aging population is like a trend. But you could even dice like the hearing issue. The deaf population is a very small, very concentrated, and I would imagine needs very different kinds of devices than the average person who is beginning to lose their hearing. And you'd be amazed the kinds of, even that, you can subdivide it into like what you're interested in. Is it hearing loss due to trauma? Is it hearing loss due to age? And the point is, by talking to the individuals who are working in that area, the organizations that are serving or advocating for those individuals, you basically start with this much broader perspective that is directed to not only the needs, but the resources that are there. And so if you go back to those principles of community engagement, that 2 and 3 that said get to know the community, that's what that's about. The principle about meeting people halfway, being humble, basically, is all about the listening part. You don't want to come in with answers. What you want to come in with is energy, inquiry, and really trying to move towards discovering what is the reality is. Okay, if we move over to this next question, do the same thing. And thank you, everybody. That was great feedback. Okay, so moving over to the next one. We kind of hashed through the hearing loss one, but if you're already there and you're already thinking of an area, who would your partners be on in any of those areas, but if you had a community partner? Patients? All of the above. I like it. Mm-hmm. Give me a little bit something more specific. If you haven't, this could also just show that you haven't really thought about it a whole lot, but which is fine, obviously. Legislators, okay. Yep, make change happen. Yeah, this is. I'm going to come to this one for sure. This is a huge issue. Let's see. In the interest of time, let's just leave it at that. So this person, who said this?
I did, Sabrina.
Hi, Sabrina. What are you thinking there?
I just think it's important to have assembly people from Congress or your senators, just to be able to really make a difference, because you could have as many ideas as you do, but you really need people on your side to help make it happen with approval and getting it out into the community, just to have a bigger impact. Man, I tell you,
you basically just went for the jugular. Before I got into research, I actually did tobacco control at a state level for 10 years. And I would venture to say that what we did in tobacco control, keeping adolescents from beginning to use, helping people quit, and more importantly, creating smoke-free environments and clean indoor air. It was before your time that you couldn't take a flight anywhere without being, sitting there while everybody was smoking on the plane, right? You didn't live through that. You can still see that in some countries, but that doesn't exist anymore in the US. In bars, you couldn't go to a bar and enjoy a drink. If you were a non-smoker, enjoy it, because you'd be in the smoke. But this is the very top of all those circles that you were looking at. This is the top of the food chain. If you start with this in mind, you are so far ahead of the game, because you have already moved from change at the individual or even at the provider level to change at a societal level. So instead of just going back to the hearing aid example, I can tell you that the weak link on the hearing aid issue is how much those damn things cost. And if you don't believe me, talk to your grandma, talk to your parents if they're older that might need a hearing aid. and see how much these Bluetooth enabled hearing aids cost and how much is actually paid for insurance. And you're going to be amazed at how expensive they are and how little insurance covers. If this is a societal priority, you go to legislators, you go to, to policy so that Medicaid, or the insurance for the old, or Medicaid, public insurance for the poor, covers this because it's important. So that's like spot on in my book. Okay, and I know that we're really cutting it close on time. So let me stop sharing that and I will switch over to the presentation. Okay. Can everybody, am I back to the Jamboard PPT?
Oh, yeah, I can
Okay,
see it on
awesome.
my end.
So Karthik, it's at 1:40. Can I go through some quick examples, or would you all like to just go into a conversation discussion? I'll leave it up to you, however you guys want to run it.
You can go through some quick examples. I think we can probably end it 5 minutes afterwards, and then.
Okay, all right, I'll go through these quickly. But so this is some of the work that I'm involved with, and I won't go through this. Let me give you the Morris Cancer Center Community Outreach and Engagement. At Morris Cancer Center, we do have, there's the bench, right? The basic in the graphic here, the clinical, and then population. Those three come together, what is called community outreach and engagement. That's what COE is. And so this is an example of what your program could consider doing. How do you structure this? And how does BMES or the BMES chapter structure this for you? So something to consider. And I would venture to say that the aims that you see here are actually probably the same kind of aims that you would want to consider. But instead of saying the cancer burden, you would say, what are the biomedical burdens that are exhibited? And instead of catchment area, if your catchment area, in our case, the catchment area is San Diego County, but maybe you're interested in international work. We are very, very fortunate to have a totally different country, 25 miles south of us, 30 miles south of us, totally different culture. We have relationships with institutions across the border. Maybe you want to do some international work, or maybe some of you already have connections in other countries. Whatever that catchment area is, addressing biomedical disparities along that continuum. The continuum in terms of cancer is pretty much the same everywhere for other health issues. It goes from primary prevention. In the case of cancer, primary prevention would be not smoking, screening and diagnosis, breast cancer mammographies, cervical cancer, HPV and Pap tests, colorectal cancer, colonoscopies, that's screening, diagnosis, and then of course treatment, and then survivorship. In just about any area that you can think of, there's this kind of continuum all the way from prevention to people who survive, right, going through it. And then this issue of disseminating evidence-based practices, this is a huge thing that doesn't happen. All of you are being trained as scholarly disseminators. There's a great infrastructure for scholarly dissemination. It's called scientific meetings and manuscripts, publications. But where's the infrastructure once you begin the dialogue with the community to disseminate and have conversations with the community about what you're doing and how they've contributed? That doesn't exist. So I can tell you that under the ACTRI community engagement, we're going to begin to set up those infrastructures and teach and train people not only how to develop community academic partnerships, but how to also deal with what I call practice dissemination instead of scholarly, in conjunction with scholarly dissemination. And then of course, this other issue that, engaging partners and so on. Let me skip through this. Let me give you an example, a specific example that you should understand as bioengineers. We are actually on a grant called, it's part of the California Initiative on Advancing Precision Medicine. And this is called the Celsus Project. And this project is basically looking at triple negative breast cancer in Hispanics. Already, this is a clue, Latino women. Well, if you go and you look at those statistics, remember when I disaggregated the obesity statistics and I said, hey, look at the differences between Blacks and Hispanics. They have so much higher obesity. Well, when you look at triple negative breast cancer, guess who it affects? African Americans and Hispanics. We don't need to go into triple negative breast cancer, but the point is, they're looking at a population need. They're looking at the epidemiology and so on and so forth. And they're looking at precision oncology, cancer stem cells, so the bench science piece, immuno-oncology, and then our area, cancer risk and disparities, and then community outreach and engagement is kind of bringing that along. So at the first level, this is the bench one, right? Identification of drug combinations to target pathways. I'm reading the aim on the left. Identification of drug combinations to target pathways specific to each triple negative breast cancer cellular state. All right, that's bench, man. Functional genomics, and sensitivity models generation. Doesn't get much more basic than that. Aim 2. Now you're moving down a little bit. Preclinical evaluation of drug combos targeting specific. Now you're talking about the bedside, right? Dealing with patients. You move a little farther down, execution of precision medicine targeting based on genomic correlates. That too is the bench side. What are you doing with these patients? And here's our aim down at the bottom: collaborate with community partners for optimal study implementation, interpretation, dissemination. It's that dialogue that I was talking about. So let me leave it at that. And if you're looking at statistics or this kind of thing, this is a great resource. HealthDat, also an Alma Clinical Translational Research Institute product. And so that's another great resource. If I think you probably already had lunch, but I'll just leave that image there for you, especially if you're a fan of Mexican food. That's the green pozole down there at the bottom and a couple of seafood dishes up there on the top. This is a Tucson restaurant where I came from most recently. Okay, so we've talked about a lot of different areas. Any questions, thoughts, comments? Does this make sense? Am I blowing smoke at you? You know, what are you feeling? Don't be shy. Let me move it over back. I'll move it back up here. Yeah.
Well, first of all, I'd like to say it was a very great presentation, very well executed. And second of all, I feel like you had a very strong point with the imagery of this idea of bench to bedside normally being considered like the words are linear in a fashion, but really it's more of an interconnected web, and being aware of like how there's so many different populations and different ways to impact local populations emphasizes this web-like nature of how research and industry can interact with communities.
Excellent points, and you're totally right. And you'll notice that on the example that I was giving for Moores, it was circular, right? You had bench to bedside, and then the community outreach and engagement in the middle, and then that graphic then that the CTIS had was also circular. But here's the reality. The reality is that bench gets the big money, clinical gets the second biggest money, we get nothing. Population community gets practically zero. And some of that has to do on the health and biomedical side of things. Our society is not focused on prevention. And it's focused on curative, and it's focused on symptom management via drugs.
That's what makes the most money.
That is what we have in our healthcare system. Now, if we had a prevention system and a true prevention orientation, I'll give you the perfect example because we're living it right now. Look at the countries that were able to divert COVID most successfully. They have true public health. Australia, for example. Another example, gun control. When there was a mass shooting in New Zealand, it only took them about 2 weeks to totally change their gun laws. Now, granted, New Zealand had very strong, like England, right? You really can't, there are not a lot of firearms there. I don't know how many millions, I mean, I think it's like 200 million or something. There's enough, firearms for every man, woman, and child in the US. So we're starting, the Second Amendment, we're starting somewhere else. But the point is, places that have prevention, that have a prevention orientation, that have public health, that circle of bench to bedside to community is a little more balanced on the research side, on the resource side, even the research, I would say, on the work that's being done there. But those are great observations. Others, any thoughts, comments? And I think we've got a few more minutes before. Anybody gonna? It sounds like some of you are thinking this way and are there. What do you think? I mean, does this make sense? Do you think some of those resources would be useful, going to like the community toolkit, the principles, the CREST trainings, and so on? Or what are things that you would think would be would be most helpful for you as you become bio, engineers and try to bring this on?
I think we still have a long way to go because I don't think bioengineers are just deemed to stick to the science field. And I think we need to think about more than science, more in humanities beyond science, so that science and humanities can merge together for maybe a better humanity in the future. We just can't say. I don't really know, but I think sometimes we just can't say, you know what, we can just do this in the science way, but if it is not linked to the humanities, then there's no compliance to that.
Yeah. Well, I can tell you this. You'll find some things much, much easier, right? A public health student cannot easily cross over to engineering. Number one, don't have the math. Number two, you all think in a very, very different way. By the way, one of probably the most important things that you as engineers or bioengineers can teach us is your iterative approach. You have permission to fail. You have permission to test, retest, test, fail, retest, test, fail, retest. In the health sciences, we don't have that, believe it or not. And we should have that. Our designs, our research designs, if you haven't heard the statistics, it takes 17 years to get from a research study to find something that might have application in practice. 17 years. You guys don't have the luxury, guys and gals, you don't have the luxury of that. You're tasked with creating, especially in industry, right? You're tasked with creating a product. You have timelines, you have deliverables. And if you don't create that product and it doesn't work, you're sunk. And that is what we need from you. So it's definitely a two-way street. So I think there's a lot of opportunity, but at the end of the day, even if you're dealing with tissue, even if you're dealing with animals like that nice little squirrel down there for Neil, at the end of the day, ultimately though, there's going to be a consumer. There's going to be an individual using or looking at, what you're working on. And I would say if you're in the middle of it, rather than having the testing people or these other people that really don't understand, they don't have the depth that you have, being in the middle of it and having those dialogues, those relationships, I think it's just a much more rewarding reality. So maybe we can leave it at that.
Yeah. I just want to say thanks again, Dr. Jesse Nadora, for taking the time to discuss your work and also emphasize the community aspect of the bench-to-bench side approach. To everyone else, this is the end of our keynote speaker presentation, but we do have other events coming up, specifically the MD PhD panel, which is, I think, going on right now, and speaker session number 1, which is also, if these topics are interesting to you, feel free to reach out to us, and we're happy to help you out in anything that you're interested in and provide your resources that could help you in your future aspirations. Yeah.
Thank you, everybody.
Thank you.